Hello. Thank you for joining us this evening to learn about what's involved in an assessment at Starjumpz for neurodevelopmental conditions such as autism and ADHD. I'm Jo Brett. I'm an occupational therapist and CEO at Starjumpz, and I'm delighted to welcome you to this talk from Dr. Georgie Siggers, consultant neurodevelopmental paediatrician and clinical director at Starjumpz. Over the past 10 years, Georgie's been working with us to develop our holistic assessments and integrated services. And I could spend about an hour talking about her experience and why we're so happy that she's part of our Starjumpz team. But I know everyone wants to hear from Georgie, so I'm going to hand over to Georgie. At the end, there'll be time for some questions. So there's a comments box. If you want to type a question in, I'll be monitoring the questions and I'll hop back in at the end and ask Georgie your questions. So thank you very much, Georgie. And I will see you a bit later.
Okay. Thank you, Jo. So I hope that I'm going to be able to get the slides up. I'm probably going to need Jo to just come back on. Oh, there we go. Perfect. So yes, so welcome everyone. I'm going to hopefully give you an overview of what's involved in a developmental assessment, and then obviously be able to answer any questions. I thought it would be quite helpful just to start off by thinking about the aim of assessment, because I know that there, many families come to us with slightly different ideas about what they want to get out of the assessment. I guess for a lot of people it will be to explore whether there is an underlying neurodevelopmental condition that might explain particular challenges that their child is facing. So the assessment may well lead to a diagnosis if that's felt appropriate. I think for a lot of people, the benefit of the assessment is to develop a greater or deeper understanding of their child's particular sort of profile of strengths and difficulties. And from that, to be able to then develop a support plan. So it's, I guess in most situations, people are coming to us because there is a concern. Sometimes it is a curiosity, but that's unusual. There's usually a concern, whether that is a concern about a child's functioning at home and at school, or one or the other, that varies. And we do have questions on our forms about what you're hoping to get out of the assessment, and that's really helpful. So that can help us to just sort of make sure that we're doing our best to absolutely meet those aims. So I just thought it might be quite helpful just to talk a little bit about the different types of assessment in general, but also at Starjumpz. So I think when people are looking for a neurodevelopmental assessment or an autism assessment, they will probably be advised that the assessment should follow NICE guidance. Now, the NICE guidance is actually interpreted quite loosely by the people have different interpretations of it. The NICE guidance on the assessment of autism is actually extremely comprehensive, and it covers an awful lot of things which a lot of NHS assessments just can't possibly meet. And actually a lot of independent assessments, they may stick to part of it but not to it in its entirety. You'll also probably come across people saying that it needs to be with a multidisciplinary team. Interestingly, the NICE guidance actually doesn't say it has to be with 2 people, but we find that doing the ADOS with 2 people is really important, because it just adds to the quality and the robustness. But it is possible to have a single assessment. The assessments that we do at Starjumpz are 2 professionals, so there would be a paediatrician, so either myself or Dr. Veronica Leclexio, and then usually it's one of our highly specialist speech and language therapists who've been ADOS trained. Sometimes might be a psychologist or an occupational therapist. But at Starjumpz, we also have other types of neurodevelopmental assessment. So we know that, you know, for some families, the full paediatric joint assessment may not actually be necessary, or it might not be achievable. So there are different ways to have a developmental assessment. So my colleague, Dr. Anna Russ and Vanessa Carter, they do a combined autism ADHD assessment. Then there's Emily, who is a clinical psychologist, and she does a very thorough autism assessment. And then there are options to have the ADOS on its own, which is not a diagnostic assessment, but sometimes that might be the bit that families are waiting for in an NHS pathway. And then if they have that with us, that could then be used to sort of as part of their NHS assessment, or with the preschool children. We'll often, because for preschool children, it's not really value for money to have a full neurodevelopmental assessment, because there's not so much, you know, there's not so much that we can do. There's not, so for example, if you have a 2 or 3 year old child, we could be doing some sort of assessment to think about ADHD, but it's very unlikely that it would be appropriate at that age. So, and a lot of the other assessments of mental health are much more applicable for teenagers and older children. So we are sort of doing more and more for the preschool children, having a slightly different approach where they have the ADOS with 2 speech and language therapists, or a speech and language therapist and an occupational therapist, and then an appointment with a paediatrician before or usually afterwards to look at all of the paperwork and meet the child and do some other shorter assessments, and then reach a conclusion. So what are the components of the assessment? Well, the way I like to think of it is that we are trying to piece together a puzzle, and there are lots of pieces, and they're all really important. And to have a very thorough, robust assessment, you need to have as many of those pieces as you can. It's not always possible, but ideally you would have them all in place. So the pieces are history from I should have actually put in there the child. So obviously where applicable, we really want the child's voice to shine through our assessment. So history from child and family, history from school. So I think that's an important thing just to mention, because we do see a lot of children who are home educated, and so it can be a little bit more challenging to get background information, or they might be out of school because they're in burnout, and so it's not going to be possible to get somebody who's currently working with the child in school or in other education facilities to complete the background information that we would usually request. And sometimes that you know, worries people. So there's always ways around it, because what we're really just trying to gather is as much information as we can. So actually having information from somebody outside of the family is really helpful, because it's their view of how that child is functioning away from their parents. So if they are in school, then it's a comprehensive form that we ask a teacher who knows the child well to complete, but it could be a swimming tutor, or it could be family member or a friend who sees the child on a regular basis. Or if they feel that those questions are not applicable for them, or they're too detailed for them to answer, they could just send a letter outlining their observations and experiences of this child. Other professionals, so it's really helpful to have copies of past reports. I think sometimes people might worry about sending those in, especially if they've perhaps already had an assessment that hasn't reached a conclusion that they're happy with. I would say it's always really helpful, and I think it makes for a much more robust assessment if you've included, referenced and considered that previous assessment. we will always be fresh eyes. But sometimes I think it's probably more worrying to other professionals reading the report if they subsequently find out that actually this is the second assessment this child has had and we've not known about it. So referencing that first assessment, and then if we do have a differing opinion, actually being able to really clearly and carefully justify that different opinion in the report is I think safe and robust. We send out a lot of questionnaires in advance of the appointment, and that's for us, you know, there are ones that relate to mood, to anxiety, to sensory processing, behavior. It's for us to get as thorough a picture as we can. We do some what we call unstructured observations, so just in general things about the child, about how they are in the waiting area, whether they've been able to greet me, how, you know, are they looking comfortable, are they looking relaxed, are they looking really anxious, how are they when they come into the clinic room, are they immediately curious, or do they sit very quietly, do they need, you know, what sort of level of support are they needing from their parent. And then we try to be as absolutely flexible as possible, because we want this assessment to be an enjoyable experience for the child. And obviously some children are very happy to come, and you can see from the moment they're there, they're enjoying it. And for others, it's a really difficult experience. And so we're very sensitive to that. And we want to do whatever we can to make a child feel most at ease, because we're going to get much more valuable information if a child is feeling comfortable. In an ideal world, we want to have some time with the child and their family and the child on their own, because that replicates school. And sometimes we know that children are presenting in a very different manner in school to how they are with their family. And so actually for us to see what they're like with their parents and without is really helpful. So for some children, there's a really stark difference, and that helps us to understand why school may or may not be seeing challenges. And for others, there's no difference. But it's how they are with and without their parents, but it's also how they respond to the separation that can be really helpful. But we would never force that, and we hope that just a child will feel comfortable. And we do use, you know, the first bit of the assessment, the child is just away for about 10 minutes in a nearby room, and then that's with the other professional. So that allows me time to have some time just to talk to parents about their concerns without a child present, which can be helpful. And then when we do the ADOS, if possible, the two professionals, we will stay with the child, and the family, the parents have a break. But there's no, you know, set rules around that. So if your child is not going to be able to separate from you, then we will accommodate that, and give you instructions whether to step in and help, or whether actually for this particular part of the assessment we need to not give any assistance. And then also with the observations, I certainly make a point of thinking about how has the child been before and after the break. So we have quite a long break in the middle of the appointment whilst the ADOS is discussed and jointly scored, and then the child and family come back afterwards. And that's helpful because sometimes perhaps if a child has felt or been a bit on edge in the first bit, they may seem more relaxed later on, or there may be no difference. So, but that can just also help in building that picture. And then also find out the observations made during the feedback. So at the end of the assessment, when explaining all the findings, is just helpful to see how engaged a child is in that process, or if they're much younger and they're not so interested in the conversation, what are they doing to occupy themselves during that unstructured time? That's really helpful. And then we do the structured assessment. So we do the BPVS to begin with. So that's a British Picture Vocabulary Scale. going to talk through each of these things in detail, but then we do the ADOS 2, which is the Autism Diagnostic Observation Schedule. And for children 6 and above, we try the QB check, which is a validated screening tool for ADHD. And we do physical examination, and then we do usually a fine motor task, which is also a really helpful observation of a child listening to instructions and then executing instructions. And then just very occasionally, there might be some other things that we feel are going to be helpful as part of that we might add in. So there's comprehensive background information is requested in advance, and I know it's quite arduous, but it's so helpful, and I score all of that in preparation for the assessment and will have read all of the documents. I make notes and I try my best to remember everything, but it can be many hundreds of pages, but it does mean that I've got a good sort of grasp of the concerns or challenges and strengths before child arrives, and then that is really helpful for lots of different reasons, but what really does matter to us is the child's experience of the assessment. So what we don't want to be doing is spending a lot of time talking about negative things and talking about worries in front of a child while they're listening. So actually we try and keep all of the history taking that happens in the assessment as really positive. So just talking about what you're good at and what you like doing. So that's the aim of the getting all of the part of the aim of getting all of the information beforehand. Some families fill in that paperwork in great detail, which is really helpful. For others, it's it's quite brief. I would say that the more information that you can give, just the more thorough an assessment it is, really, because it's more for us to consider. We get you to complete lots of different questionnaires. So I've just got a list of them here. So we do ADHD rating scales, we do an autism questionnaire, we do an anxiety scale, moods and feelings, we do the extreme demand avoidance questionnaire, and a sensory profile. And then depending on age, we've got some others that are really helpful. So the CAT-Q is particularly helpful for teenagers because it explores camouflaging and masking and is really helpful. And then with the history, so the background form that parents and carers will fill in covers everything really, but it is trying to sort of find out about early life history and then current functioning. So I think sometimes people might look at the questions and think, oh, say for example their child is 14 or 15, they might look at the questions and think, oh, this is really not relevant for our child because it's talking about kind of quite basic skills. But there are particular questions that might be relating to now, but there are also a lot of questions about in the past. So it is helpful, even though you may have a very able child, to still fill in those things as best as possible, because that really helps us to paint a much and create a much richer picture of child's strengths and difficulties. And then I've mentioned a little bit about the assessment already, but these are the components just to get outlined again. So the unstructured observations, gathering some further history, the BPVS, looking at fine motor skills, the ADOS, the QB check, and physical examination. And these are just a few of the things that we would be thinking about with those initial unstructured observations. So we do have various interesting items in the clinic room, and it's fascinating. Some children come in and sit and don't move, and others immediately notice things, the sensory pictures on the wall, or the little fiddle items that are usually on my desk, or boxes of things, and are very curious, and that it just helps us to just gather a little bit more information about their personality. So then the BPVS is a really helpful screening tool that we use. It's actually a screening of understanding of single words, and it's validated and standardized, so we can get a standardized score and we can get an age equivalent. And we do that because it immediately gives us a better idea of a child's level of understanding of language. There's also a strong link with verbal IQ, so it can give us it's not completely robust, but it gives us an idea around cognitive ability. But it also gives us a lot of behavioural observations. So it's very interesting, different ways in which children may approach this task. So the task is that either myself or speech and language therapists working with me will say a word, and the child has 4 pictures and they have to choose the word that best matches, and there's a correct answer. Some children point, and they point in exactly the same way, or they may have a very fancy way of pointing and they do that throughout. Others will chop and change and will say the number of the picture, and then they might point, then they might describe the picture. Some children don't want to say anything, don't want to point themselves, but they might get a favorite cuddly toy that they've brought with them to give the answers for them. Lots of different ways. Some children will approach this and only do what they've been asked to do, which is identify the pictures, and other children will start chatting about the pictures and ask questions, and suddenly they'll see a picture that sparked a memory and they'll start talking about that. Some children might seem oblivious to the fact that we're writing down answers and that there probably is a right or wrong. Others are highly sensitive to that and you'll see them peering over and trying to check whether they're getting them right, or they'll actually repeatedly ask, how many have I got right? And we just try to keep everything as positive as possible. But it's a very helpful tool that we use right at the sort of start of the assessment. And then we do the ADOS, which is, again, it's a very structured assessment, a validated assessment tool. And there are different modules depending on your child's age and level of speech. And some they have an overlap in terms of some of the tasks, but not all of these things will be used in the assessment. Most of the time we're doing what we call a module 3, which involves some play with toys, a puzzle, looking at a book, looking at a picture, some chatting, creating a story, a demonstration task, looking at some cartoons. The older children and young people don't do the play bit, and it's more talking. But they will still do the book, the picture, creating a story, and the cartoons and the demonstration task. And we work through that. One of us will be actually doing those tasks with the child, and the other is watching and taking notes. And it's really helpful because we can miss things. So some of the things that we're looking for, you have to be actively looking. So facial expressions and how they're directed or not directed, gestures. When you're in the middle of a conversation or in the middle of play with a child, it can be easy to miss those things. So having the other person whose sole focus is watching and writing is helpful. So because then once we've finished all of the tasks, child has a break and we then discuss the findings, and it's a very methodical way that we have to go through that and score. And then we're scoring as to whether there is a very obvious autism related sign, and that's all that we've had training to identify, and it's very prescriptive, and we have to have the evidence to give a score. Most of the time we probably have consensus, but there are, in every assessment there will be probably 1 or 2 areas where we may be deliberating a little bit and going through the evidence a little bit more, because there are certain things that can be a little bit more complicated. But then we agree our scores, and then from those scores, there's what we call an algorithm, and that pulls out a certain number of the scores, and they're added up, and then you'll hear people talking about a cutoff. So depending on which module, module 3, for example, the cutoff is 7, and you're looking for a score sort of in excess of that to be consistent with evidence to support a diagnosis. But it's not an exact science, and we know that some children with ADHD, the score can be higher than it probably really is because of some of their ADHD related symptoms that have interfered, and sometimes the ADHD can actually artificially lower the score. So there's a lot to it that we have to discuss and work out. And this is just an example of one of the tasks in the ADOS. So this is looking at a book, and that's the picture that we use. So it's the same. We have one book for the younger children. Actually, we have 3 books. One for the very young children, one for the middle childhood children, and then one for older children and young adults. But it's the same, and wherever you have an ADOS, it will be the same kit, it should be, and the same way that it's scored and performed. And then we do a fine motor task. So we have a 4-page little booklet, and there's a little bit like the BPVS, there's lots of things that we get as sort of extra information from doing this, but it's very straightforward. We ask a child to copy a series of shapes, then write their name in a particular area, and then copy out capital letters, copy out numbers, and do a drawing. But there are a few little things in that task that tell us a lot. So it tells us a lot about child's ability to remember the instructions, to listen to the instructions in the first place, how keen they are, their speed of working, how they're holding their pen or pencil. There are a few little red herrings in the task, and it's whether the child notices. It's really interesting. Some do, some don't. Some may not appear to have listened to the instructions and just assume they know what to do, and then struggle and miss the kind of attention, the finer detail of the instruction, but at the same time notice something that's a little bit unusual about the way that the letters are printed, or it's amazing how many things you can tell just from this little task, but it's really helpful. And then we do the QB check. So the QB check is a standardized computerized assessment looking at symptoms of ADHD. We describe this as the world's most boring computer game. There are 2 forms of it. There's for the 6, so it's validated from the age of 6. Not all 6-year-olds will be able to do it. Some manage it amazingly well. Others, it's just too hard. But equally, we can have teenagers that can't do it because they're just too impulsive. It's quite hard. The younger ones have circles that appear on the screen, and they have to press when they see a circle and not press when they see a circle with a cross, and the images come quite quickly. And then the older children have a series of shapes, different color shapes, and they have to press when they see a repeating shape. So it's all about attention, ability to inhibit the impulse to press when you don't need to press, but it also is tracking movement. And at the end, it gives us a really helpful graph, and it compares to a validated sample base, and then we can look at differences. And it gives a score out of 100. Anything above 10 is suggestive of ADHD, and the closer you get to 100, the stronger that evidence is. But it also then gives us a breakdown of movement, of impulsivity, and then attention. And it gives us these clever graphs over time. So you can actually see for some children their difficulties with inattention are present right from the beginning, and for others they maybe have a really good performance for 10 minutes and then they can't sustain it. But that can be helpful when you're thinking about planning study times and when to have a break, etc. So there's again a lot of information that we can get from this. We've been doing this for a long time now, so I think it's coming up to 9 years since we started. I started using the QB check, so we have done thousands, and we see patterns, and it's really interesting the different patterns you can get, whether you're autistic without ADHD, autistic with ADHD, or ADHD. And that's something that the company, I've talked to the company about, and it's being replicated. So it gives us a lot of helpful information. And some children can't do it, but actually I always encourage them to try. It can be really hard to anticipate whether a child is going to be able to do it or not. I'm caught out all the time, kind of think to myself, really don't think this is going to work, but I do want to try it, and then child actually sails through it. And other children where I think, oh, it's not going to be difficult, and they just can't access it. But actually just watching what happens is evidence that we can then include in our analysis and in the report. And then we do physical examinations. So we'll be checking growth, head circumference, blood pressure, heart rate, listening to child's heart, just looking at their general appearance. So have they got any unusual physical features, birthmarks, palm creases, shapes of fingers, ears. So the reason that we're doing that is we want to obviously exclude an obvious physical condition that might be contributing, but also looking at potential syndromes or chromosome imbalances or sort of indicators that could suggest that. Also, I would say very common for us to see hypermobility, and I think it's really important to identify. There is a lot of evidence linking hypermobility with autism. There's more evidence now coming out about more sort of complexity, that hypermobility with dyspraxia, with ADHD and autism and other things. And so actually it's really helpful to identify. It's also important because it could just be, it's another thing that a child is having to work harder to overcome, or it's another thing they're having to cope with if they've got achy, tired muscles. It's a cause of fatigue. So when you're thinking about everything that a child is actually having to cope with on a day-to-day basis, knowing that they're hypermobile is really important. I always am fascinated by the fact that I can have same age child with the same list of conditions, and yet the way that those conditions are impacting them can be completely different, and the way that they're presenting in school can be completely different. And so it's really important that we think, why is that? So the more that we can find out about everything a child is dealing with, I think it leads to much more useful recommendations and things that are going to make a difference. Sometimes you may have a child who is autistic and ADHD, functioning actually very well, but what's having the biggest impact for them is the fact that they're struggling with their handwriting because they're hypermobile and they've got some fine motor difficulties and they've got perfectionist tendencies. So it's really stressful and frustrating for them because they want their handwriting to be neat, and they see their classmates get their pen license and they're not getting their pen license, and that's the thing that's having a day-to-day impact on them, not their autism and their ADHD as such. So actually they may have get their diagnosis, but if you haven't identified that, you're not really going to be able to put in place everything that you need to do to mean that their life is going to be a bit, a bit easier. So yes, just so we're also, I always think it's a good opportunity just to have a brief health check. Sometimes we find something that is, not related to neurodevelopment, but also important to identify. So every so often we find something very interesting and for us exciting, but actually important to identify and to refer on and include in a plan, because it could be another thing that is having an impact. So reaching a conclusion, how do we do that? Well, we are basically taking all of the evidence that we've got from, so all those pieces of the jigsaw puzzle, and we are trying to build a picture of the child's functioning and how all of those things will be interacting and affecting them. And when we're thinking about a diagnosis, we use the DSM-5 diagnostic criteria, and we're looking for the evidence that those criteria are met. And I think that's important to stress, because the DSM-5 criteria for autism, you have two sections to it, and the first section, section A, is your communication, your non-verbal and verbal communication, and your social interaction. You have to meet the criteria in each of those sections, but the range of difficulty within each of those sections is broad. But in the next section, you have to meet two of the criteria. So, and that's where I think sometimes it gets so complicated, because it means that you can be autistic without a special interest, because special interest is just one category. But so often we get mainly schools saying, but this child doesn't, this child doesn't look autistic to me, or this child isn't like another child I know who's autistic. And then they might have a little bit of doubt over the validity of a diagnosis. But actually it's really important, when you look at those criteria, it helps you to understand why there's such a variation in presentation of autism. But we're looking for we have to have the evidence that fits into those criteria. But you can have all of the evidence, but actually I would argue that you wouldn't have a child coming for an assessment if there was not an impact. But there has to be an impact to make a diagnosis. So that's where, if you hear people saying, well, we're all a bit autistic, aren't we? We might be, but if it's not having any impact on our lives, then we wouldn't be seeking a diagnosis. So when we mean impact, we are thinking, is it affecting your functioning? Is it causing complications in terms of your mood, your anxiety levels, your ability to meet your potential in school or meet your potential in other aspects of life? We then have to be clear that these symptoms have not just, say if we were seeing a 16-year-old, have we got evidence that these symptoms and signs have been present from early developmental period? That can be complicated, because we know masking is really complex, and for some children in the right environment, their autism doesn't necessarily show. It's always a little, we have to think carefully about that. I would say that most of the time, if we have a child where, and it's quite common for nobody to have sort of noticed really anything very different through primary school, and then things become really challenging for a child in secondary. And often that is because there's ADHD as well, and there's very complicated ways that ADHD can mask some of the autism symptoms, but we really need to think about that, because if you have a child where absolutely the evidence is that there was nothing, and then all of this has happened at age 14, 15, then you really have to be thinking about, is there something else that could explain that? And people may have heard of PANS, pandas, so there's things, and other kind of more mental health psychiatric disorders that we would need to be thinking about. The other diagnostic criteria that we have to satisfy is that there is no other explanation. So by other explanation, we mean sort of other developmental conditions or intellectual disabilities that might explain the picture. And then we have to be thinking, is it in the best interest of this child to make this diagnosis? And I would say it usually is, but there might be some very specific situations where maybe it's not the right. It may still in the future be in their best interest, but it might be at that moment it's not. And so we are really sensitive to that, and would always be looking to discuss that more, because we really do want to ensure that by making a diagnosis, reaching a conclusion, that that's going to be a helpful and positive outcome. So sometimes, I'm particularly thinking about teenagers, they may not be ready for that. It's also important to say that if you're if you're planning an assessment, thinking about an assessment, thinking about how you want to hear the conclusion. So I feel that when a child has worked with us all morning, and they usually have been given some reason for coming, which we do sort of ask about at the beginning, but I feel that they need some feedback. But completely respect families' views on that they may not have used the words autism and ADHD yet. Sometimes they've been having those conversations for quite a while, and the child is prepared that might be something that we will be talking about at the end of the assessment. But it's really important that we know where you are with that, so that we can give some sort of, it might be that we just give some sort of feedback, looking perhaps at the QB check pictures and telling a child how well they've done and what we've noticed about their strengths. And then they go, and maybe they go with one parent and go and have a walk, or maybe they sit with headphones and watch a film while we're talking. But we will adapt so that is as comfortable as possible. Other children, even from quite a young age, are involved in that feedback process. I think what we want to avoid is a very sort of stressful, worrying end of an assessment, when a child is then sort of pushed out of the door and knows that the adults are talking about them, and then because of the way that all the adults are looking and sounding, that must be really worrying, because that could feed into there's something wrong with me. And we want this, I feel really strongly about when a child learns about their neurodiversity, that it's positive. But it may be that it's on that day isn't the right time for them yet. And I do think that it's important that parents are ready for that, because their child's probably going to have questions, and if they're not ready and prepared to answer those questions, then it might be that it's best to wait and parents process that information and feel confident that they can have a positive discussion about that with their child. And it's done, and some parents prefer to sort of a drip feed approach, and maybe you'd use different words to explain it first of all. It really varies, but we want it to be comfortable, and would respect individual families' views. So important to let us know. And sometimes people they'll send an email in advance and say, you know, they're worried about anything being discussed in front of their child, because the child is so sensitive to these types of things, and we will accommodate. So I thought it might be helpful just to talk a little bit about what I kind of think of as special considerations, because, you know, say that the majority of children that we see cope with the assessment. You know, lots do enjoy it. For some, we are then sort of like, oh no, that felt, you know, like we were torturing them. We really weren't, but we hope they're okay. You know, we do try really hard to make it as enjoyable and relaxing as possible. But there are some children that we see where they are so anxious and stressed that you know, they're not going to, it's not going to be possible to do everything in the way that we want or ideally want to do it. So again, we try to be as flexible and accommodating as possible. We get some children who really not compliant and can't engage. We have various ways. I mean, I think we haven't been beaten yet, but it's been close. But we have done assessments out in the garden, sort of out in the grounds. We've done assessments in the car. We've done many assessments in the sensory room. So if the sensory room is not being used, we will relocate there. We will we kind of try lots of different ways. We have assessed quite a number of selectively mute children. It's challenging because obviously we can't get a lot of the answers, but some children will write the answers for us. But we adapt and just try to get as many observations and as much information as we can. Preschool children, I think it probably works, certainly 2-3-year-olds, I think it works better splitting the appointment, and that's something that we're starting to do more and more. So you come on one day and have the ADOS with the speech and language therapist, and then come back on another day and see me, because it's a long time. It's, you know, the assessments are 4 hours. It's a long time for a young child. So I think that works quite well. A lot of times we get contacted in advance of the assessment, sort of just asking questions about girls, and will girls that mask, and will we see that? And we do. I think that we've been obviously doing this for a long time. I think that in those situations there are extra questionnaires that we might ask for. It's really helpful if a family let us know that they suspect that their child is going to be masking with us. We will usually see it, but actually it's helpful to have that on the forms, and it usually is there. And it's usually evident because the school will fill out a form without any evidence on it of anything that they're seeing. So you know, there are clues to us. And then, so I would also say that we do see quite a number of children who have learning disability, and that obviously, depending on the level, can make the assessment much harder to access. But again, we have ways around that. But we would always discuss, you know, if there's something that you anticipate could be particularly challenging, then talk to us about it, because we would see if we could come up with some way of making it as easy as possible. And then next steps. So as I said, I can have the same age child, a same boy or girl, with exactly the same list of diagnoses or associated challenges, and they will be completely different from the next child. So I feel that it's really important that you get a profile of your child, what their strengths are. Not obviously those already, but what we as professionals see as their strengths, what we see as the challenges, what we see as the impact, why it's having this group of conditions is having this impact. Because we can have children where they are seemingly functioning very well at home, but not in school and at risk of exclusion because of the challenges they're facing, or the complete opposite, where they are masking and extremely compliant in school, but really distressing and challenging behaviour at home. We can have children where there are challenges in every environment. It's really important that you have it. I always think that the diagnosis is opening a door, but actually once you're through that door, how has it helped you? I know it has, because you have to get through the door, but you need more than that. And I think having the profile is really important. It's really important for parents, but it's particularly important for the young person, for them developing that understanding of themselves. So many times we hear of children who've made an assumption that something is happening because of something else, usually that, feeling that they're bad or mad. So actually helping, there's sometimes the sense of relief that they get when they realize that there's a scientific reason for this. It all makes sense. It's very powerful. And I don't think that you can fully understand a child unless you have that unique profile, because otherwise assumptions will be made, not necessarily by parents, but by other people in that child's network, maybe based on their experience of working with an autistic and or ADHD child. So I think and interestingly, that profile is in NICE guidance, but it's sometimes a bit that's missing, because it is hard to pull all of that together. But what I'd hope you would go away from the, obviously not, you get the feedback around that, but you'd then get in the report is that picture of why are these things happening? Why is school so stressful for this child? Or why is it that in this environment things are so much easier for this child? Because it's from that you build the most useful strategies and recommendations. So we try to give as much feedback as we can at the time. Obviously, there might be reasons why, if the assessment has been particularly complicated or challenging, that we may not get as much time to do that, or maybe if child's not coped with the assessment, but we would always sort of offer to do that on the phone afterwards if that's not been possible, or to come back, but we do try to give as much of that feedback on the day as possible, and then sharing the information with the child in a way that that either coded or open, whatever's going to be comfortable. Some in that feedback, some immediate sort of ideas about things that can help, but then in the report, so I do a summary which I try to get out to as soon as possible, but I would say within 2 or 3 weeks of the appointment, and that has all of the recommendations that are then in the report, so that you can get started on those, because the full reports, they are very detailed documents. That I guess probably on average they're about 55 pages, and both professionals have contributed to that, and then we both have to check it. So it does take a lot of time. So that comes out around 8 weeks after the assessment, but we've been working on it during that time. And then we don't sort of, we're not prescriptive about follow-up. NICE guidance does recommend it, and I think it can be helpful for lots of different reasons. But it's if it was free, I would be saying it's important for everybody. But actually, in the old days with my NHS work, we would have routine follow-ups after every assessment, but then for capacity reasons that stopped. And it's a shame, but I think when we're working independently, obviously if parents want to come back and have an appointment with me, that's absolutely fine. We'll do that. But there's probably other avenues that you'd be better investing your money in. So, like an occupational therapy assessment or some speech and language support, but we'll talk about that at the time. But some parents do want to have or book an online appointment to talk through things, and that's fine. We'll try and accommodate that. So it's just on an individual basis, really. Sometimes it might be quite a way down the line. That's always nice to see families again, or it might be particularly with the children with ADHD, it might be that now our medication service is through another organisation because of all of the infrastructure that you need around and governance around prescribing controlled drugs. But we do have some avenues to support that, so that might be another way of different type of follow-up. So thank you for listening, and there might be some questions which I'm happy to answer.
Hi, Georgie. There are some excellent questions. Thank you. I will start firing them away at you. Okay, I'm going to scroll up to the top. So, would your assessments recognise pathological demand avoidance or PDA? And that's the first part of the question. So we'll start with that.
Yes. And it's really important to recognise because of the strategies that are needed and the understanding, but also because that would be happening for a reason, and we need to be then thinking about which is predominantly anxiety based, but thinking about what is contributing to that anxiety and actually what can we do to reduce that anxiety, because then we may find that the sort of level of demand avoidance changes, and we see that a lot over time.
Yeah, and from an OT perspective, there's often a lot of sensory issues that can be underlying that anxiety as well, difficulty coping in different environments causing anxiety.
Yeah, absolutely.
I know you do take this into account, but do you take into account high masking at school?
Yes. So actually, I should have talked a little bit more about that. Sometimes when the team are sending out all of the paperwork to be completed, we might get a message back from families saying we don't want to ask school to fill out the form because we know that they don't see anything, they don't believe us, and it's not going to be useful. And I do understand that, but I would say that actually it's a very important piece of the jigsaw. So there could be some very small things in that information that's shared that actually can really help us to work out what might be causing stress for this child. Or if they really, if they're not seeing anything at all, we really need to know that. And we see it a lot. And it's interesting with the ADHD rating scales as well. So and the ADHD rating scales is a score above which is clinically significant in support of ADHD, but there's a considerable sort of range below that would still be considered as typical. But I would say that most children should score something, and a lot of the children that we subsequently identify as masking will score a 0, which to me is like they're like a robot, and they're almost not human in school. And we see that so often that it must be a pattern of presentation where it's part of that sort of overly compliant, fawning, camouflaging child. So having that is a very helpful piece of evidence. It's not going to be something that is going to mean that we can't make a diagnosis. We have to think about it but even if we have very strong evidence, we're still thinking about it because it's just part of the assessment.
Yep. There's another question on PDA, which, do you ever see it noticed at home but not in school, and therefore maybe sometimes not in the assessment, but it's being noticed at home?
Yes, so it's a presentation that is an interesting presentation that is important to identify. So I would say that there are some children with PDA where they are demand avoidant with whoever they're with in whatever environment. And I do a lot of work with the PDA Society, and we have a lot of discussions around these different presentations of PDA, because I actually think in a way those children with PDA are kind of protected. I know what's challenging is that very high numbers of them will end up coming out of school because school can't meet their needs and their behavior is so challenging, but in a way they're then protected because it's so obvious that they have needs. The children that I really worry about are the children who have PDA profile at home but not in school, because they are doing that they're either they're having a really negative experience to be behaving like that a lot of the time. They're overly compliant. They are suppressing that instinctive need to say no, and that's probably really difficult for them. So it's kind of almost the opposite of what some people might be thinking, is how we sort of view that, and is actually very important to identify, because usually the demand avoidance at home is the sort of barometer of what's going on in school and how safe and supported that child is feeling in school. And you see it change when a child does have the right support. So yes, we do, and we see it a lot actually. And we would interestingly, we will either see the similar picture to school and we'll have the overly compliant child, or we'll see more of what parents see. And actually we can sometimes see that change in the assessment. So we might have a completely compliant child who's done everything that we have asked them to do in a way that is just not quite natural, and then it gets the QB check and they can't actually they can't do the QB check, and they realize, and that's when their PDA sort of flares. Or we'll see a child who has been all over the place and hasn't actually done anything that we've asked them to do, but we do the QB check and then they sit there angelic, completely still, focused, and they do the QB check. And it's incredible the difference we can see, but actually that's really helpful for us because there's a reason why that's happening.
Thank you. Need very good observation skills for noticing these changes that can even happen in a short period of time with you. A question we've had is, can an assessment be inconclusive?
It can. I would say that it's not common, but I've had probably in the last couple of months, I've probably had 3 or 4 you wouldn't go away without anything from an assessment, because you would still have a very detailed profile of your child's strengths and difficulties. I would say that what can sometimes happen is that the assessment leaves me so baffled and confused that I can't give you a really confident answer on the day. And when that happens, I go away and go back over. And sometimes when I'm going back over and starting to write the report, it all then is a bit clearer. And so then it might be that following up from that, we have another meeting to explain. And it might be that then subsequent, or it might be that I need to get some more information. And that can happen now and again. So it might be some more questionnaires, or it might be arranging for somebody else to go into school and see them, or for me to do something else. But I would say that we are quite tenacious and want to, we want to be able to reach a conclusion. Obviously, if we've seen a young child and we don't have, that sometimes it may be that their ADHD is very obvious, and we've got a bit of a suspicion about autism as well, but we don't have enough evidence. But we would always then explain that and say that that's something that we do need to revisit if needed, or it might be the other way around. So we might have, we see quite a lot of 3-4-year-olds where I'm already sort of seeing evidence of ADHD, but maybe the evidence is not completely robust, so it wouldn't, and it is more challenging in the younger ones to make a diagnosis of ADHD. And you've got to have, you have to have really clear evidence, and you have to be really confident of it, and you don't want to make the wrong decision. So sometimes then it's better to put that on hold and say, look, it won't be another full assessment, but it might be that if these things continue, you can come back for a follow-up in 6 months or 9 months, or we can get some more information at that point. But I would say that I don't think that we've ever seen a child and not, so when you say inconclusive, it might be that we feel very confident that there isn't this, and this. But I would say it's much more likely that parents actually come thinking that their child may have one thing and they go away with more things. That's probably more a common scenario.
Thank you. We've just had a question come in that's probably relevant to what you've just been talking about, which is that some psychiatrists speak of the difficulty of untangling the symptoms of autism and ADHD, particularly in girls. And as you do more assessments, is this getting easier? I know this is an area of your specialism.
That's a really good, it's a really good question. But it's difficult to answer because it's almost like the more you do, and I was thinking, I've been working with Starjumpz for 10 years now, and I have done a scary number of assessments in that time, but I've also had, the real sort of privilege of following up a lot of those children. So I'm seeing some of those children that I saw in that first year still. And so you see more and more, and actually then every time you see that a child for follow-up who's autism and ADHD, you see a different aspect of it presenting. So the more I do it, in some ways, the more complex I feel the whole thing is. But I guess also I'm understanding it more and I'm seeing more of the conflict. But we can see things change within the assessment. We can see aspects of it. So it's really fascinating. But I guess in that way, because we know so much more about different ways it can present, it's getting a bit easier. But I think that there are the more we do it, we see some very specific patterns of impact that you only get when you have autism and ADHD together, not when you have one or the other. So that actually can help us. And we've got more we've got more and more evidence of the stories that you get in the lead up to assessments. So lots of, I guess, a very common, which I wouldn't have necessarily recognised 8 years ago, but I now, if I'm reading that, it's an immediate sort of like, oh, I wonder if, is a family that might say, we've decided to have the assessment now because of XYZ, but actually we have been a bit concerned on and off, but we've gone through phases of thinking, oh, maybe our child has ADHD or autism, and then maybe no, we're thinking that no, that we've gone through a period where everything seems to be sort of settling down a bit, and then something will happen, and then concerns escalate, so that we do see sort of particular patterns of stories, but also what the young people are telling us themselves, and when we listen to them, they usually give, they're able to tell us what's going on. They may not realize the significance of it, but that can be really helpful. And what they'll usually describe is conflict. I want to be organized, but I can't, or I want to be neat, but I can't. I want to move, but I don't want to get into trouble.
We get quite a bit of feedback from the young people that you see in very positively, that it's helped them to understand themselves when you've helped them to see what might be a symptom of one or the other condition, which, is really amazing. And I think it really makes a huge difference to those young people when they can understand what's going on.
Yes, they get their light bulb moment. They're like, oh, and actually, and it can be such a relief to them, because it's so confusing to them if they want to be able to do something in a certain way, but then they can't. So they want to go and do something really exciting, but then they're fearful of a new environment. In that makes no sense to them, but that makes complete sense to me in the context of autism and ADHD. So I can help them to explain that, or they may find that the way they feel about that changes day to day, and then that makes them worried that there's something far more sinister going on for them. And so it's then a relief for when we can say, well, actually that's really typical.
Which is great. We've had some other questions about are you able in the diagnostic assessments to look for Tourette's, stammers, facial tics, things like licking things?
Yes, so sensory processing difficulties we can identify, but I would always then, if a child hasn't had an occupational therapy assessment, recommend, because I've got a level of understanding of sensory processing, but it's not to the extent that an occupational therapist would have. So and it's so complicated, and what you want is in the same way as I'd be hoping to give you a profile of a child's strengths and difficulties in the sort of context of specific neurodevelopment, an occupational therapist would do that in terms of that child's sensory profile, which is really helpful. But we would identify sensory processing difficulties. Absolutely would diagnose Tourette's if the evidence is there, or a tic disorder, or an anxiety disorder, or dyspraxia. So if we see those things, because I think and if we've got the evidence, so dyspraxia, we need the evidence from an occupational therapist or a physiotherapist together with our evidence. So if that hasn't been done yet, but we see evidence of it, we would recommend that happens, and that we then, if they find that their standardized assessment gives the evidence that we need to meet diagnostic criteria, we revisit that. If they've already had that, then we can confirm dyspraxia or developmental coordination disorder diagnosis at the time of the assessment. I would say the other thing that comes up quite a bit is ARFID, so the avoidant restricted food intake disorder. I feel it's if we're doing this very detailed assessment, it's important to identify as much as we can of what's happening for that child. And some people will say that that's like over-diagnosing, or it's giving a shopping list of things for a child, and actually there's people have different views about it. I personally feel that is really, really important, because you need to be able to consider how all of those things are impacting. But if that's something that if families are they just want an answer about ASD or an answer about ADHD, then let us know, because it might be that one of the other assessments might be better value for you and more appropriate, but we'd always want to be able to be as flexible as we can.
Yeah. Somebody has asked if it's an autism only assessment, would it look at things like extreme anxiety, social anxiety, and agoraphobia, or is that really where the full holistic assessment that you've mostly been discussing cover those things?
So I think that Oana and Ness, with their autism ADHD assessment, they do sort of mental health screening around anxiety and mood disorders. So I would have thought they would pick up and make comments on that.
Yes.
But I wouldn't be expecting Emily's assessments that she does. I think she would probably sort of make a reference to that, but I don't know whether she would diagnose those associations.
Yes, and another question was, do we diagnose mental health conditions? But I think you've covered that in what you've just...
Yeah, so my background is I've done a lot of CAMS training when I was training as a developmental paediatrician, and then I've also worked in CAMS team. So I'm probably a little bit unusual in that sort of having more of a crossover. But I don't have the experience and expertise to, for example, diagnose childhood schizophrenia or bipolar disorder or personality disorder. So I feel that my mental health sort of experience is within the context of neurodevelopment, if that makes sense. So I would be able to diagnose depression, a mood disorder, anxiety disorders, Tourette's, but not the other mental health conditions.
It's an interesting question here. When a child is invested in getting a diagnosis for autism because it would explain to them a sense of alienation from a peer group, do you ever do the assessment and find out they're not at the threshold? And then how would you handle that with a teenager, say a 13-year-old? Don't know if you've come across that, but I suspect you probably have something similar.
So I know there's been a lot of concern about TikTok raising awareness about particularly ADHD and autism, and therefore young people having much more information about it. But I would say that it's more common, this is from my experience, it's more common for a teenager to not want to have an assessment to find out about neurodiversity than it is for them to kind of create it and convince themselves that they are, particularly autism, because I think there is still within the sort of young people, there's more of a stigma around being autistic than there is about being ADHD, which is a shame. But that is, I think, I hear that a lot at the moment. So I would first of all be wanting to really explore what it is that young person has identified in themselves that makes them think that they might be autistic, because there's probably something that they're experiencing that is causing them some distress or difficulty that needs to be explored, whether that's autism or not. But there could be so many things that are contributing to that. But I would really want to find out more about that. And is it bullying? Is it what is it that's going on? And then importantly, what can you do to make that easier?
Another question, what would happen if you can't get a teenager to come for an assessment, and if they're unable to leave their house for maybe a few months, or having difficulty attending school? Actually coming outside the house is difficult. What would you suggest?
Yeah, so I think this is really happening more and more. But actually, I've probably had maybe like 10 children where that's happened over the last 5 years or so, and we've tried different things. So I think that it's always going to be better if they can come, because I think going through the assessment process as I've outlined gives you so much information. But it does, there are ways of helping a child, in what is a very distressing situation without doing that assessment. So I suppose it's like different things we've done over the years is, first of all, we would try different ways to see if by having pictures of the centre and pictures of us and some more explanation about what's going to happen in the assessment, whether that might alleviate some anxiety. Or sometimes we will have visitors, a couple of weeks before the assessment, and come and say hello just in preparation. Or, we're very open to that. Families can drive to the centre, not get out of the car, or get out of the car, come in and say hello. So we would always accommodate things like that. Also, things I've tried is that, maybe doing a short appointment online, either with parents just to begin with, just to get more of a sort of sense of what's been happening. Sometimes if the child would engage in that, just maybe even just for a couple of minutes, but sometimes it's a bit easier if they've seen me and said hello, that maybe then the next week we could have a longer appointment and then we build up. I've had some children where I've gone to their house to see them. I think it's not my favoured approach, because I think home needs to be a safe place, and actually if you don't know who I am, then me coming to the house is an invasion. And actually my experience has been that more often than not that young person has not wanted to come and say hello. So it's not actually been that helpful. If the child is engaged and saying that they want to have the meeting with me and talk to me, but they don't feel that they can actually leave the house, that's a little bit different, and I try and accommodate that. And that has happened several times and has worked out quite well. I would say that there's also, just getting all of the background information and questionnaires can at least give us some idea, and it might be that we could then give a sort of part opinion of what might be happening and come up with some recommendations. It might be that there might be some interventional therapy that you could do before diagnosis, before assessment, that might then make it easier for that child to then engage in the assessment. It just very much on an individual basis.
So last question, are assessments accepted by the NHS? And I believe I'd be right in saying that it's very important to you and to our assessment team to make sure that the wording that's used in the assessments is such that parents will be able to go on to get, for an example, an EHCP plan if it's appropriate, education and healthcare plan if it's appropriate, medication if it's appropriate, an access card, that sort of thing.
Yes, yeah. So I mean, that is something that is very, very important, that we've tried really hard over the last 10 years to build up that reputation, so that people would have trust in our assessments. And we still occasionally come up with challenges. It's usually we will hear from a family that the school have said that they can't take the evidence from this assessment because it's a private assessment. And I would say that if that happens, we really want to know about it, because I want to speak to that person to find out why. Because we've had, say for example, we've had a school in East Sussex say that they won't accept our assessment. East Sussex commission us to do assessments. So you can't, I don't feel it's right that you can say for this child, because the local authority are paying, we're going to accept your opinion and we want your opinion, but because the family have paid, we're not. Because it makes I'm not doing anything different in that assessment, whether a family have paid or a local authority have paid. And half the time I wouldn't actually necessarily even know who has paid. It's exactly the same quality and assessment process, irrespective of how you've ended up there. But I would say that we do have a good reputation. There's a trust. The East Sussex NHS team work very well with us. The Kent team work very well with us. We haven't had any challenges. Again, because we do commissioned work for Kent and East Sussex. I think, we do have challenges with the HCPs, but it's not because it's come from Starjumpz. It's because it's a challenging area anyway, and the advice that we give, whether it would have been if it was an NHS paediatrician or a Starjumpz paediatrician, could be challenged. But we would always say, if you ever got that feedback, to let us know, because I would want to speak to the person that's given you that information and just see what there's been a misunderstanding somewhere. What can we iron out about this? And actually legally, our reports are used in many tribunals, and the judge would always take the evidence. Legally they have to. It can't be dismissed. So I would say it's more often that we get we get lovely feedback actually from our allied professionals than we get problems.
Yeah, we work closely with local authorities, as Georgie's mentioned. We also do a lot of adoption support assessments, and our therapists do a lot of the education and healthcare plan support in schools. So we're really familiar with what's needed in terms of what goes out in the reports. Just to mention, Georgie, Claire Lucas's service, which she's been starting for after an assessment, if you want to see a very specialist speech and language therapist who's worked for many years with children with neurodevelopmental conditions, Claire is offering a service with her where she can follow up on the assessment with you if you'd like to speak to someone like a speech and language therapist, and she can help signpost you further to next steps and give really good support. And if you've had an NHS assessment or are waiting for an assessment and want a bit of help beforehand, that's another way that Claire can also help to support. I don't know if there's anything else you'd like to say, Georgie, before we finish. We've had lovely thanks and feedback and some amazing questions. But I'll leave you to say the last word, Georgie.
No, so just thank you all for listening. If any of you are thinking about an assessment, then I look forward to meeting you. And if the team at Starjumpz are so helpful, and if you've got any questions about anything, just let them know. And yes, I hope it's been helpful.
Yeah, so email us info@Starjumpz if you'd like any more information or want to ask us any questions. Thank you, everyone. Have a lovely rest of the evening. Good night.
Bye.
Bye.